Welcome to Pediatric Pioneers, a MedBridge podcast where we conquer challenging topics for the pediatric therapist through conversations with pioneers who have blazed new trails in our practice. Our aim is to deliver actionable takeaways for practitioners like you. To receive continuing education credit for this episode and access bonus resources, make sure you check out medbridge.com. Hello, I'm your host, Nicole Quint, and I'm an occupational therapist with over 20 years of experience in practice and academia, specializing in pediatric practice and the improvement of occupational participation and performance through my expertise on executive function, visual perception, social emotional learning, sleep, and sensory processing. It is my passion to support pediatric therapists like you so that you can best serve the families under your care with evidence-based practice solutions, easy to implement advocacy approaches, and new ways to lean into your skills within the challenging pediatric landscape. Hello, today I'm excited to be joined by Dr. Wendy Stav, who is an expert in the area of occupation-based practice. Dr. Stav is an occupational therapist who has her PhD in occupational therapy and is also recognized as a fellow of the American Occupational Therapy Association. We'll be diving deeper into the topic of occupation-based practice, including recent research and actionable takeaways you can implement right away with a focus on pediatric practice. Welcome, Wendy. Could you get us started by sharing a little bit more about yourself?
Sure. So I've been an OT for 30-something years, and I love occupation-based practice, and I've been in academia for about 20 years, so I have the pleasure of teaching that approach to students and sharing everything about it.
So tell us a little bit more about what initially attracted you to this topic of occupation-based practice and how your passion has evolved over time.
Well, I came upon it by happenstance. For about 20 years, I did all things driving and community mobility, and I loved it. But for me, it wasn't really about the operation of an automobile. It was about how much traveling out in the community allowed people and enabled people to engage in occupation and really fulfill their lives. So after about 20 years, I was ready for a little bit of a change. And I realized that everything I did was really grounded in my foundational belief that there's a relationship between occupation and health. And we all believe that as members of the profession, but I realized that while we all believed it, it was a little bit nebulous, and we didn't know what it looked like. We didn't know what occupation-based practice looked like, how to measure it, were we doing it? So that was sort of my calling to really change my scholarship to look at occupation-based practice.
So you found your purpose within occupation, right? So share with us a little bit about what you mean about occupation-based practice. You said it was nebulous. Can you give us a little bit more of a definition that we can use?
Sure. So I define it as the use of meaningful doing as your therapeutic approach, so that you're using occupation as your therapy to work towards an occupational goal. So the occupation as means and ends of your therapy.
So, if a child has an occupation as a goal, let's say something like an activity of daily living, or maybe something that's education-based, we use that as the therapy? That's our therapy mechanism?
That is a great question. You could, but you don't have to. So I actually really want to dispel the myth that you have to use the occupational goal as the therapy. It's unrealistic to think that, let's say a child has to work on their clothing management during toileting. I can't just show up every time the child has to use the restroom. So I have to create these occupational opportunities so that they can learn those clothing management skills. I can use that outcome occupation as my therapy, but there's no rules that says I have to. I can use lots of other occupations instead that are meaningful to the child.
So why do you think it's important to discuss occupation-based practice and pediatric practice and school-based practice? I mean, that's pediatric-based as well. And what questions should we be asking as clinicians? Is there anything we should be questioning in our roles as occupational therapists?
Sure. I think we should always be asking, what am I bringing to this team? So there's lots of disciplines on the team: physical therapists, speech therapists, pediatricians, psychologists, reading specialists. What am I bringing that's different? And what the thing that we bring that's different is occupation. It's that occupation-based approach. So it's great to use that sort of interprofessional team or interprofessional practice jargon, for lack of a better term, but we have to bring our profession, because the idea is that they're all sort of coming together. So the more each discipline brings their own perspective, the more comprehensive a package of services that we're providing for the child. And in addition, if I'm doing something different than the other disciplines, that's going to avoid any type of duplication of services. So when budgets are tight and funding is cut and insurance wants to stop paying for certain services, we don't ever want to be in the position where we're providing something that looks exactly like what another discipline is doing. It really keeps us unique and valuable and prevents us from being eliminated.
Yeah, it sounds like you're really wanting us to lean into our niche, right? With occupation. So,
Sure.
you know, we're always talking about things being evidence-based and using best practice approaches. So what does the research say about using occupation-based practice? Can you give us some highlights of the most important takeaways so we know this is a supported approach?
Yeah, there's a lot of evidence out there. I would tend to sort of cluster it into categories. The first of which is really theoretical and grounded in our philosophical base that speaks so heavily into the relationship between occupation and health and how we can use occupation to generate healthy outcomes. I definitely want people to think about this broad view of health, like the World Health Organization talks about health as not being merely the absence of illness, but it's physical, social, and emotional well-being as well. And that's exactly what we want for our kids, to have this sort of overall global well-being. So we know, based on what our theories tell us, that engaging in occupation leads to health and survival and well-being and happiness and inclusivity and justice. And that's exactly what we want for the kids that we're treating. The next sort of group of literature is documents that leaders in our profession and our organization have put together that tell us, here are the guidelines. They're all based on research evidence, but we have lots and lots of guidelines, from the very generic and general, like the OT practice framework, all the way down to very specific practice guidelines for early intervention in schools and the role of OT in the NICU and textbooks. So that's a little bit more general, but there's quite a bit of research out there as well that tells us when we use occupation in practice, we generate better outcomes in our clients. And I really like to rely heavily on systematic reviews, because it's such an efficient way of understanding the literature, because a systematic review or an evidence-based review looks at big chunks of articles, multiple studies, and interprets them for us, the user, so that we can be consumers of that literature. And we know that there are evidence-based reviews that were coordinated by AOTA that say when we use occupation in practice, we generate better outcomes in ADLs and IADLs and play and leisure and social participation. We can, and rest and sleep. We can get much better outcomes. So we know we want to use occupation because it'll create better outcomes. There's also some evidence that tells us what that is like. We know that it's not easy to use occupation in practice. There was a study that looked at early practitioners who had recently graduated, and they acknowledged, wow, it's really tough to talk about it. Even though we just learned about it, it's really tough to talk about it. And the context that we work in, whether it's the environment, that makes a difference. So being in a home or school, really naturalistic environment, is much easier to use occupation than if I'm in the hospital. And the culture and the organizational structure of where we're working, that also makes a difference. So our documentation systems, our billing systems, our IEPs, that all sort of lays the groundwork for how easy it is to use occupation in practice. And one other thing, because we always want to start off on a good foot, when we're working with any client, we know we always start with the evaluation process. And there's some research that looks at occupation-based assessments and what does that do for the rest of our practice if we use assessments that are more occupation-based. And we know that if I use an occupation-based assessment, that starts me off on this very positive trajectory. I write more occupation-based goals. I use more occupation-based documentation. I provide services in a much broader variety of spaces. I use more occupation-based materials. I involve more family and friends and significant others in that care. So if we can start off on the right foot by making good assessment choices, that puts us on the right path.
Mm-hmm. So, yeah, and what you're referring to sounds to me, occupation is the top, and we're using more of a top-down approach in practice than, I hate to use the phrase trickle down, but then it starts to maintain its presence throughout our OT process with that child and their family.
Absolutely.
So it sounds like there's a lot of evidence. You talked about systematic reviews. You've talked about even some studies about the assessment tools to use that really support occupation-based practice. And that's really exciting. And I wanted to talk a little bit about how we can translate that research into the clinic or into our practice specifically. Are there certain patients or conditions for which this would be the most appropriate?
Well, we all are occupational beings. So occupation-based practice is applicable to every single child you see, regardless of the setting, their age, their diagnosis. We all, as humans, need to engage in occupation, and we're going to get better outcomes. So it works with every single client.
So we could do this whether you're in school, private practice, community hospital, vocational programming, all of it.
All of it. In the community, in the schools, in the hospitals, everywhere.
So how do you see this potentially playing into practice? So let's start with the evaluation process. Let's guide someone through how to start to add occupation-based approaches into their practice.
Okay, so first I would start to look at the assessments that we're using in pediatric practice and start to look at what those instruments are. What are we using to measure the kids that we're treating? So what do those tools look like? Are they capturing occupations or are they capturing skills and behaviors? Are they using materials that are occupationally relevant? So a hairbrush for grooming rather than hold this pen and pretend to brush your hair. Are we using contexts and environments that are natural to the occupation, or even considering that in our evaluation process? Are we capturing meaning and what's meaningful to that client? Are we asking them to execute some sort of task or activity, or we're just asking them some questions? And at the end, when you're done, what kind of goals does that assessment lead you to write? The information that I yield from that assessment tool, does that lead me to write an occupation-based goal or a goal to improve their skills or behaviors? So we need to use the right tools, but maybe we don't have the right tools to use. So we also really need to advocate to get those tools. When the director says, hey, we have some budget money to spend, say, I know we can order some really occupation-based tools, or advocate for acceptance of scores on those tools, not just tools that will give us, percentile rankings.
Mm-hmm. So, you said that there was a study that went into occupation-based assessment tools. Can you give us the names of some specific tools that that they identified as being occupation-based that we could use in practice?
Tools like the Pediatric Evaluation of Disability Inventory, the CAPAC, which really looks at what occupations children participate in and enjoy, the role evaluation of activities of life, the school function assessment, the COPM, the MFUN, the Miller Function and Participation Scales. So there's lots of tools out there that yield great information of this child as an occupational being, and how they engage and what they engage in and what they want to engage in.
And most of those assessment tools are probably more affordable than some of those big kits that we associate, with standardized assessment tools that do more of the, percentiles and maybe the deficits of the child. We're used to those being very expensive. These sound a little bit more maybe reasonable for a clinic budget.
Right.
Okay. And so I think there's also some play-based assessment tools in there as well, I would hope.
Tests of playfulness.
Those are important.
Yeah. The COSA, the Child Occupational Self-Assessment.
Okay. So, you've got me thinking. So what do we do in terms of using occupation-based treatments? That's the fun part, right? We've assessed the child. We've used maybe test of playfulness, or we've used the MFUN or the COPM, and we have some rich occupational information about this child as an occupational being. So what do we do now? As we're planning our treatments with this child, how do we infuse occupation-based approaches into those treatments?
So there's no cookbook that we draw from, right? Because if it was a cookbook, that would be all of the occupations that I personally want to engage in. And since by definition, occupations are doing that is meaningful to the person, there is no list to draw from. We're looking at what that child likes to engage in. It's not always easy to do. And I want to, before we get into interventions, I definitely want to acknowledge that when we do interventions that are a departure from occupation, it is not because we're bad therapists. It's not because we're lazy. In fact, on the contrary, we know that therapists work really, really hard in very complex and demanding circumstances, but there are very real barriers to using occupations in practice. And we can't ignore the fact that they exist, but we have to take some action to sort of counter them.
Mm-hmm. So let's talk a little bit about those barriers, because I know I've experienced them. I hear therapists talking about them all the time. They're very much real. and they present quite a challenge to therapists. So let's go over those barriers and really think about some solutions.
Okay. So the first and most obvious is the physical environment. So we don't have a space that permits occupational engagement or the materials and the tools to do those occupations. It's really difficult to infuse occupation in practice. So if I'm working in the school system and they give me an old janitor's closet, that's my OT room, and I have some pegboard that was left over from a previous therapist, but I just ordered some pencil grips, and that's all I have, right? Paper, pencil grips, pegboards in an old janitor's closet. It's going to be really difficult to use occupation-based practice. So that physical environment is one thing we have to get past. The systems that we work in can also be a very real barrier, whether it's the culture and expectations about what I will be doing with a child, time limitations, the expectations of administrators or the referring physicians or the teachers. Maybe it's our documentation system and the lack of latitude in being able to write about occupation. Insurance guidelines. One big barrier are these very formulaic IEP goals that come down in a pull-down menu rather than being allowed to write what that child needs and recognizing them as an occupational being. Sometimes even the way that we practice. In one of my first jobs, I traveled. I was in a huge school system. I went to 15 different schools a week. And in some of those schools, I had one child. So I would park my car, run in, see this kid for 30 minutes. I didn't even know where the bathroom was. And I was out the door because I had more schools to get to. So there was no way I had the capacity to generate, ideas and resources and environments and establish relationships with the teachers to be able to meet that child's occupational needs. And by the way, who says an occupation happens in a 30-minute window? That's not how we engage. We're forced to practice in a way that conforms to an existing delivery model. And even our own perspective can sometimes be a barrier, and what we believe as what is occupation-based practice and how much it can influence health and how much training that we've received, and do I have opportunities, do I have people around me with opportunities for intra-professional collaboration? If I'm working in a clinic, I want you there so that I can eat lunch with you and brainstorm and talk about my own growth and my own identity as an occupation-based therapist. But if I'm flying solo, that's much, much harder to do.
Yeah, that peer mentoring is really important to growing and engaging in some mutual problem solving, right? To kind of overcome
100%.
those barriers. And those barriers all resonate for sure. I think all of us can relate to what you were speaking about. What do therapists need to consider when it comes to this perspective of other stakeholders, such as the parents, their care, the clients that we're seeing, other care providers? Are there talking points that you could suggest, or word choices or strategies that you would suggest for us that would aid in the buy-in and the carryover of occupation-based practice?
Yeah, word choice is so critical. And the number one word is occupation. We can't forget it. I one time had a doctoral student, he said, it is our first name, right? Occupational therapy. It's our first name. We should go by it and not just be called, the therapist or it's time for therapy. There are so many stakeholders that we need to really get on board with what we do and what we have to offer and how I as an OT can make an impact on this child, but I have to use that language all the time. And keep using that word occupation and not shy away from it because people don't understand it. That's okay. We need to really embrace the language of occupation and use it and document it. And, the sign outside of our clinic should say occupational therapy. I don't even like using the acronym OT or OTP, which is at this point even more confusing because the occupation gets lost. And parents and insurance companies and referring physicians, they need to understand that what that child is getting is occupation, not just therapy. I've been called OTPT before, going to the classroom to get a child for pullout, and the teacher sees me and says, "Oh, it's time for OTPT." Well, I only have the 1 degree, and it's different. It's completely different than physical therapy, and that's okay. I love that it's different than physical therapy, but I need to be recognized by my identity. But cast a really broad net, and every time you introduce yourself or sit at an IEP meeting, don't be afraid to just keep throwing out that word occupation and little Johnny's occupational engagement and his occupational identity. Just keep throwing it out the same way other disciplines do with their language.
Yeah. And so, these are things that we can lean into. You said, don't shy away from occupation, lean into it. I like that you said it's our first name. And I know when people talk to you and they call you by your first name, you're more engaged. So I think that's a great trick. So, we started talking about the barriers, and I think that's really important. We're appreciating the environmental barriers, the system barriers, even the name being confusing. We need to lean into it and help people understand. So let's go back into, like I said, the fun part of treating, and let's give some specific examples of how to use occupation-based practice with our pediatric clients.
Sure. I think that we need to look at the materials that we're using, the spaces that we're providing, those services, and think about who that child is as an occupational being and where they engage in those occupations. So I mentioned that janitor's closet. Think of that space as your storage room. I remember having that humongous bag that I had on my shoulder that I brought in with me to the school, or walking down the hall with my big bag of tricks, and that was great and allowed me to be creative. But the materials and the things that a child, for example, in the school system, the things that they use, or a child in the home, the things that they use, all those objects, they're right there. They're surrounded by them. We need to really take advantage of the spaces and the materials that where people really engage. And that idea about the janitor's closet, that's not where a child would engage in the school system. I'm thinking about schools right now, but they would engage, getting on and off the bus, in the classroom, on the playground, and in the cafeteria, and in art class, and in PE. That we need to be supporting their occupational engagement and really capitalizing on those occupational opportunities in the context where they match, right? So, so it makes sense. There's some context to their doing, and the child can understand it a little bit better. I might change my delivery model too, depending on the child. We get so honed in on these 30-minute sessions that I can maybe get a little bit richer in my occupation if I have an hour-long session every other week, right? Instead of half an hour a week, or even a really intense 2-hour session once a month with some training to the classroom aide to help support things. But I have to look at that child and who that child is as an occupational being and what their occupational needs are. So if I have a child that has some social participation needs and they're out on the playground in recess every day, that might be really the perfect place to facilitate some social co-occupation with their peers. And now I'm really meeting that child's occupational needs, not just skill building.
Mm-hmm. Yeah, and you bring up co-occupation, which is so important too. But, this might sound a little basic, but I think it's important is actually even identifying what are occupations in the school setting for children. We think about it from education standpoint, and I know sometimes people get a little honed in on handwriting. I've always said handwriting's not really an occupation unless you're into calligraphy. It's a form of communication, just like speaking. So what are some school-based occupations? Because I think school is a little different than when we think about ADLs and things like that. So could you give us just some examples? Because I think that will ground everyone in what you're talking about.
Sure. I think kids do engage in ADLs in the school system. They engage in toileting, they eat at lunchtime and at snack time. They might engage in, hand washing. They engage in IADLs, whether it's, they're cleaning up around their space. It might be work like chores, the assigned, lots of classrooms have chore lists and things that they have to do. They certainly engage in social participation, which I think is a major area that we are missing in the school system. Play, all kids engage in play and leisure in the schools. We do get really stuck on handwriting, though. Maybe it gets extended to cutting. And, for a child, maybe they are having that issue, but in terms of seeing it as an occupation, is it communication? Is it education? I mean, for 6 hours a day, they're engaged in the occupation of education. Mm-hmm. Now, part of that engagement requires them to write and read and cut and glue but also participate in PE and, line up walking to an assembly and, use the restroom and wash their hands. There's a huge array of occupations that children engage in during the school day. And you'd probably be better at identifying how it got reduced to writing. But it's probably not much different than adult practice that gets really reduced down to, very reductionistic skills.
Well, you're in a system and sometimes you conform to the system is kind of what I always say. I think too, in the school system, it's tough because you have experts in reading and sometimes I think it's easy to think, well, maybe we don't have that. So we avoid those occupations without realizing we can, do interprofessional practice, we can suggest strategies, but we forget about things like doing research for a project. We forget about things like having to, make an outline, having to write a little paper, written expression. Maybe we're taking notes.
Organize a backpack.
Oh, yes. You worked on that a lot and notebooks. Right. So those are big.
Now that we're talking about it, it reminds me of some of the things that Mary Riley has said, that some of our biggest issues are the commonplaceness of what we do. Mm-hmm. And things like organizing your backpack and managing your pants after you use the restroom, it looks so ordinary and commonplace. It's not from an OT lens, but it's not very flashy. It doesn't look specialized to the naked eye, and that naked eye would be the teachers and the parents, and it's a bit of an identity issue that we have in general, that because we don't really own occupation, wear it like a badge of honor, it feels too commonplace, or looks too commonplace, so it doesn't feel special enough. So if I say, well, with this special pencil grip, I can get this child to write legibly, that looks more official.
Yeah, I think the identity piece is an important part of it. That's why I think your approach of really embracing that occupation is special. It's a privilege to get to work with people on their occupations, because that means you really get to know what makes them tick. I think is something we need to really lean into. So I love this school-based approach. And obviously, OTs work in the school more than any other setting, but we have a ton of pediatric therapists who work in the home or in the clinic. So could you give us an occupation-based example of that setting?
Yeah. Oh gosh, I love home health because the context is just dripping with occupation-based practice, because the spaces and the materials and the people in that home are natural to a child's occupation. So again, like in any other setting, it's really critical to see that child as an occupational being, but not just as an individual, but considering with whom they engage, right? So they're with their parents and with their siblings, and that whole family is an occupational unit, and they engage in family occupations like play and mealtime eating and chores. So now we're starting to really encroach on co-occupation and really understanding the shared doing and the shared meaning and the reciprocity of that engagement. So the doing might be the same, right? So if, for example, mom is feeding a baby or giving a bath to a child, they're not doing the same occupation, because the mom is doing the parenting occupation and the child is doing the eating or bathing. But there's that healthy engagement, there's some reciprocity, there's some give and take. That's really part of that dance of co-occupation. But gosh, the home is just right for that. So I would try to facilitate co-occupation with a sibling when you can, maybe playing a game, doing an art project, making food, cleaning up the playroom, things that a child does anyway, even when you're not there. There's all these opportunities for occupational engagement. So jump in, but involve the other party. And obviously the sibling doesn't want to do therapy either. So like with any pediatric client, you make it fun and you have races and you can pick up the Legos the fastest or whatever you're working on. But that's how a child engages. It's very organic. It's not a set of repetitions. It's organic occupational engagement. But we have the ability and the expertise to use activity analysis so that we might position something different. You put the material somewhere else, make the just right challenge to facilitate occupational engagement.
Mm-hmm. Yeah, and I think too earlier you just were talking about affordances. Basically, you were saying, you take advantage of the situation or the timing, or you make the timing. You don't always have the opportunity to do toileting with a child because you can't always be there when they have to go to the bathroom or when they have to wash their hands, but you could put them in, have them do some artwork, and then they get their hands dirty, and now you have created that affordance of washing your hands. And it's the same thing in the home. If I want to do something where we make a little bit of a mess, now all of a sudden we're working on cleaning it up, which most parents really appreciate. So,
Exactly.
You're creating those affordances to create those occupation-based opportunities as well. And I think, the home health environment makes a great opportunity for that. When we're thinking about, you kind of talked earlier about the barriers, and you talked a little bit about, how we can advocate. It came to mind to me that electronic medical records are also another barrier in the system that, again, it's like the reps. how much time, everything's kind of reductionistic. And do you have a quick way to get around that, or a suggestion to help people with that as well? And obviously we want to use occupation in our documentation as well.
I think that's all part of the advocacy role, and what we can do to create systems that are more conducive to occupation. So when it's time to assemble the committee to review the documentation, volunteer to be on that committee and express very clearly that the OT documentation, the form in the electronic medical record needs to be different. And remember, to an administrator, money talks. So you can tell the administrator, look, I need to be documenting something that is different than all of the other disciplines so that the insurance company will never want to deny my services. And let's create the infrastructure, the documentation infrastructure, to eliminate those denials. But I think there's so many opportunities for advocacy, whether it's with the insurance company or legislatively or with administration and developing a program, or advocating to the community little league to make a more inclusive policy system to allow children with special needs to play little league or in any parks and recreation league. We have such a huge role in terms of advocacy. Unfortunately, those aren't the services that we can bill for, but it's part of our job. It paves the way so that we have a job.
Mm-hmm. Yeah, it's true. It's a competitive landscape out there in healthcare, and the more we can carve out how important we are, we have research to show that our approach works, even compared to other disciplines. We
Right.
need to embrace that and really take it with us. So, I wanted to focus on maximum impact. You've talked about all these really exciting things. It makes me want to run and go do some occupation-based practice with folks and advocate too. I always get caught up in the advocacy. What would be your top 3 actionable takeaways that therapists could put into practice?
Okay, so I would say that the number one is embracing occupation as our belief system. Occupation is powerful and health promoting and transformative and magical. When it's happening.
Mm-hmm.
And we really need to embrace it as a mindset and as a way we practice. The second is we need to take every opportunity to advocate for occupation whenever we can, and whatever the venue is, with the client, with the system, what have you, budget requests, whatever it is. And the last is I would really add occupation as a foundation to your language. Use occupation in introductions and documentations and explanations and your advocacy. I don't know that you can use it too much. It's who we are, it's what we do, it's what we believe in. It is our therapeutic medium to get us to support these kids. So that's where I would.
So it's kind of like every time we use the word occupation, I want everyone to imagine the money sound, the cha-ching, right? It's money. You just used occupation. It's perfect. Yeah. And I want to go back what you said first, because I love these 3 takeaways. We want to embrace occupation. We want to use occupation as much, as possible. We want to advocate for inclusion. I want to go back to that belief system. You said occupation is powerful, it's health promoting, it's transformative, and you said it was magical. And there's something, and I know you very well, on this approach, there's something else that you say about occupation that I want listeners to hear, because I think it's really important how you say this.
So occupation is our secret sauce. It's it. This is what we have. It's our superpower. It's what makes us different than everybody else. So visualize a big eraser and that idea about it looks too commonplace and just erase that. We are so uniquely qualified to understand the occupational implications of health and developmental conditions. We're the only ones who do occupational analysis, where we'll analyze the exact performance skills and context and demands of occupational engagement. Nobody else does that. We're the only ones who know about grading and modifying activity to find the just right challenge. Nobody else does that. So we need to really harness the power of occupation. It is so powerful in changing health and recovery and supporting inclusion. It's so powerful. It is our secret sauce. We need to get like capes.
Right.
Or like a chest badge or something. Exactly.
Well, I think we have proof of this with COVID. Occupations were taken away and all you heard about was mental health. And people thought, well, it's because people are stuck inside. It's because of this. It's because we had occupational deprivation.
100%. Worldwide, we all experienced occupational loss.
Exactly.
And then we saw health declines. We saw increase in mental illness, increase in substance abuse. We saw increase in domestic violence. So there was this connection, but at the same time, we are not wired to, we're not wired to just sit and stare at the four walls. We are wired, our brains are wired to be driven toward occupational engagement. So we didn't take this order for social distancing and just sit in our homes. We started creating sourdough starters and learning new workouts and exploring new craft opportunities and having online trivia, because as occupational beings, we have a need, an innate need and drive to engage in occupation. Why would we ever want to stunt that in the kids that we're treating?
Yeah. So I love that. You know, it's like embracing the occupation. I know you said the advocacy piece, whether it's, you know, talking to the team about the IEP, and making sure that that occupation's addressed in the IEP goals or the goals that we write in our treatment plans, you know, looking at the occupation-based assessments. You talked about that earlier and trying to see if maybe we could get more of those in our practice. Looking to advocate for the documentation systems. You talked about that. So these are all really important things. And I think also taking us out of the little closet at the school, I could totally relate and connect to that, and actually getting into the area, the environment where we can do the occupation matters. So thinking about pushing a little bit on those time barriers or those frequency barriers and being open. That's one gift of OTs. We're very flexible, open-minded people. So I think that leans into our strengths as well. So that's a good thing. So we have our 3 takeaways, and you know, we have our strategies for really bringing occupation-based practice into whatever setting that we're in. To wrap things up, I wanted to just ask you, like, what final words of wisdom or inspiration would you like to leave with the audience?
I would encourage everybody to harness the power of occupation. And remember, I mean, as kitschy as they are, things like occupation is our secret sauce. It's our superpower. Remember that and not shy away from it. Really embrace it and wear it and own it. And I know it gets tedious explaining and defining what occupational therapy is for the 100th time, but instead take some joy in it and let people understand just how special it is and how much it can contribute to the clients that we see.
Yeah, maybe we can flip that script too. Maybe whenever someone asks us what it is, we see it as an opportunity to share what we do is special.
Exactly.
Yeah. Leaning into that first point you said, right? Well, Wendy, I want to thank you so much for joining us today. This has been wonderful learning about occupation-based practice. And I wanted to ask you one quick question. Is there a tool out there that we could use that we can assess our own occupation-based practice so we know if we're doing it right or what we can improve on?
There is. My colleagues and I have created a model of occupation-based practice, and then we built an assessment tool off of that model. It's available for use, but not freely, readily available yet. Hopefully, we're hoping to build it into an app so that we can measure our own practice and figure out where we are and set professional development goals. And even hospitals will be able to use it, and systems will be able to use it to measure how much their therapists are using occupation in practice. So it's called the Occupation-Based Practice Assessment. You can read about it in the literature.
Okay. And that's helpful because I think people do need to know, where they stand in terms of their occupation-based practice. So thank you so much. And I want to wish everyone some wonderful occupation-based practice. Thank you for tuning into this episode of Pediatric Pioneers by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or on your favorite podcast platform and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and complete the quiz for this episode. Pediatric Pioneers also listens to you. If there is a particular practitioner that you'd like to hear from, or if you have a question or challenge that you'd like to explore on this podcast, please let us know by leaving a comment on our Instagram posts or by emailing podcast@medbridge.com.